Today I would be discussing on the topic of enteral and parenteral nutrition in basically critical care setup. Now, medical nutrition therapy in a critical care setup depends on the severity of the illness of the patient in the critical care setup, level of the physiological stress, and finally, the baseline nutritional status before illness. Now, for the clinician to assess the level of physiological stress of the ill patient is done by certain standard scoring system, like for example, the Apache 2 and the Apache 3, which is acute physiological and chronic health education evaluation scoring, injury severity scoring or the ISS scoring, abdominal trauma index or the ATI scoring. It has been seen that if the abdominal trauma index is higher than 24, sepsis condition prevails, which has gross impact on the further management, be it therapeutically or nutritionally for the patient. And for finding out the baseline nutritional status, we use various tools like the mini assessment scale. We use the MIS scoring, which is the malnutrition inflammation scoring. We use the GLIM scoring, which is a two-phase scoring, which includes the MUST scale and alongside a second level of evaluation, which involves etiological and phenotypical various criteria. Alongside biomarkers like the albumin, pre-albumin level, immunological markers like lymphocytes are also to be noted. For the baseline nutritional status, another point of importance is a note of the past intake or the history of any poor intake prior to the critical care status, and if there is any note of recent weight loss, peri-critical care illness, peri meaning pre and during, this would actually indicate a gut assimilation problem, which will in turn affect the nutritional status and will affect the sepsis status. Basically, nutritional intervention in critical care or in the ICU deals a lot with the management of or the stoppage of development of sepsis, which leads to all the other conditions which actually becomes problematic or which pushes the patient to a further detrimental status. One thing which I would want to mention is I just mentioned about the Apache scoring. If this Apache scoring 2 along with the Ransom criterion, this is especially seen in pancreatic disease patient, who is one of the patient with which we face a lot of feeding problems in the critical care setup. If Apache 2 scoring along with 3 Ransom criteria are there, then that is an indication of implement, of upcoming sepsis and immediate aggressive nutritional management. Now, basically, we all know that enteral nutrition is always advocated over parenteral nutrition. If we look at how the nutritional therapy was viewed in the past and in the present, we could summarize it in the following points. Previously, the goal was nutritional therapy was an adjunct therapy which will support the stress management. While today, it is early initiation of enteral nutrition, not only given to manage stress, but also to ensure that there is no gut disuse which will increase the severity of the disease, along with modulation of the immune response. What I am continuously stressing is enteral or parenteral nutrition basically is given to alleviate sepsis conditions in a patient. Previously, the goal was to maintain an exogenous nutrients store or an exogenous nutrient provision to counter the reduced endogenous store, while today it is to maintain the gut physiology, and by maintaining the gut physiology have a favorable impact on the malnutritional scoring. Previously, it was just the depletion of lean body mass, while today, along with the prevention of sarcopenia, what people concentrate upon is induction of faster oral tolerance. And what I mean by induction of faster oral tolerance is basically a process where the immune response is down regulated to prevent excessive response to the various antigens which are provided or which enters our body through food, and which affects the bacterial flora in the GI system. This is basically what oral tolerance means, or could be, or what oral tolerance could be defined as. Now, if I have to argue or debate why early enteral nutrition, the pointers would be: enteral nutrition helps in maintaining the mucosal mass of the GI system. It stimulates cellular proliferation of the helper cells. It stimulates the production of the brush border enzymes. It maintains the villus height. So all these three together will actually help in maintaining the health of the lamina propria and the Peyer's patch. Then enteral nutrition helps in maintaining the integrities of the tight junctions between the intestinal epithelial cells, the epithelial lining of the intestine, the cells. It helps in maintaining the tightness so that there is no seepage of the antigen into the bloodstream, which means it prevents the increased mucosal permeability. Increased mucosal permeability will actually be leading to SIRS, which is basically the major concern in enteral or parenteral nutritional feeding in a critical care setup. It stimulates the blood flow to the gut, and it promotes the release of endogenous agents like cytokinins, gastrines, somatostatins, and bile salts. Now, why are clinicians or scientists, advanced scientists, nutrition scientists today against the overzealous use of parenteral nutrition? I was just mentioning about the Peyer's patches health. With zealous use of parenteral nutrition or early parenteral nutrition, and by early I mean within 3 days of admission, we have seen that there is a marked reduction of the villus height, reduction in cellular proliferation, reduction in mucosal mass, and gut associated lymphoid tissues, which in turn will um, affect the innate immunity of the body, reduction in the brush border enzymes. And it has been seen, studies have proved that the IgA, the various kind of immunoglobulins, especially IgA, has been seen to be reduced in the gut within 5 days of gut disuse. And in the respiratory section, IgA has been seen to be reduced even further. This particular point is of a huge relevance today in the COVID situation, because IgA is known to be having a competitive action with the ACE2 receptor sites, which actually helps in COVID virus entering our body. So this particular point is of huge relevance in today's current pandemic scenario. Now, a few key pointers from whatever I've been saying till now. Reduction in the villus height, as I was mentioning previously, the pancreatitis patient poses a huge problem for us clinical nutritionists when it comes to feeding. Villus height in pancreatitis is diminished by feeding by is diminished by parenteral feeding. Therefore, to suppress this reduction, we have to go to enteral feeding. Starvation followed by injury will increase the mucosal permeability. So if we are on PN, body will actually click that or check that off as a starvation mechanism. In burns, it has been seen that enteral nutrition is inversely proportionate to maintaining the mucosal permeability. As you can see, I am continuously stressing on the point of mucosal permeability because it is all a play between the antigen and the body's immune system, which worsens or rectifies the critical illness condition. Systemic endotoxemia increases gut permeability, which will lead once again to SIRS. Gut permeability in critically ill patients correlates with the development of organ dysfunction, which is basically the second line of what happens when SIRS set in, unless and until it is countered by CARS, CARS. Now, let me say what is the problem that happens with parenteral nutrition. Basically, when we are having parenteral, when we are feeding the patient parenterally, we are reducing the peristalsis. There is no food moving through the GI system. So basically, the body does not need to have this peristalsis movement. Now, of course, one may argue that if there is injury to certain parts of the GI tract, then of course there will be a requirement of stopping the peristalsis. But normally with a critical care patient who does not have as such any GI injury, there should not be a reduction of peristalsis. Alongside, there will be a reduced secretion of the immunoglobulins. Now, a reduced secretion of immunoglobulins and bile salts promotes something very fearsome. In our GI system, there are lots of bacteria, some friendly for us, useful for us, and some which proliferates various diseases. Now, if these unfriendly bacteria, they adhere to the mucosa, and then there will be overgrowth or overcolonization of these bacteria. Alongside, there will be translocation of these bacteria, which I was stressing so till now. Mucosal permeability will increase, and then these bacteria will translocate, they will cross the mucosal barrier, and they will go into our bloodstream where other opportunistic infection then sets in. This is also one of the way when continuous parenteral nutrition increases the chances of patients getting nosocomial or hospital acquired infection. And this is noted within 5 days of gut disuse, which happens if the patient is only on parenteral nutrition. Once again, I'll just go into the key points of what I was saying till now. Recent study shows that gut-derived factors can reach the systemic circulation via the lymphatic system rather than the portal system. Please note, this is very important, the lymphatic system rather than the portal system, and affect the distant organs. Second, bacterial overgrowth in the lumen leads to bacterial translocation, which I just explained, being a very potent source for sepsis and organ failures. The various bacterial flora which lives in the GI system is affected by continuous parenteral nutrition. Actually, the overgrowth of non-friendly bacteria suppresses the growth of the gut-friendly bacteria. If you remember, I was talking about oral tolerance. Basically, oral tolerance is noted by the immune response to the antigens, and of the amount of food that an adult takes in throughout an year, 1 out of 1 lakh actually is the intact antigen that the body intakes through food. So this argument that intake of food can worsen the condition, which had been a thought process in many clinicians for a long period, is basically completely countered by this fact, because the entire chain of event is a delicate balance of the immunological status, and if the antigen antibody system is coming into play, we can note that only 1 out of 10 lakh is the antigen or the intact immunological antigen that we receive through food. Now let me quickly explain the immunological model as to what happens when there is aggressive parenteral nutrition. Parenteral nutrition will somehow influence the dendritic cells, the macrophages, the NK cells to act as antigen presenting cells. These antigen presenting cells, as we know, will release the cytokines like interleukin 1, tumor necrosis factor. These in turn will activate the naive CD4 helper cells. Actually, the entire immune response or the inflammatory response that happens in our body is controlled by the activation of CD4 helper cells. Once these naive cells get activated, they differentiate into various helper lymphocytes. These helper lymphocytes will start influencing pro-inflammatory response, which will also increase the temperature or will induce pyrexia in the patient. That in turn will also release other cytokines, interferons, tumor necrosis factors. One thing that one needs to know out here is basically gut disuse leads to the expression of the addition of the molecules which is required for the proper attachment or the proper homing of the naive B cells to the lamina propria and the gut associated lymphoid tissues. Of these, there is basically one molecule which is known as MADCAM, MADCAM. This is basically a ligand molecule. This interferes with the normal migration of the B cells from the Peyer's patches to the lamina propria, and this leads to the atrophies of the Peyer patches. Now, atrophy of the Peyer patches, which I've already explained, will be leading to the events like less release of the antihistaminic compounds, less release of cytokines, less release of brush border enzymes, and triggering off of the pro-inflammatory responses. As I was talking about, the helper cells or the Th1 helper cells is essential for the host defense against infection, but this is basically our acquired and innate and acquired immunity. But if there is an uncontrolled Th1, it leads to self-injury. The body starts an auto injury response, or what we've often seen in cancer patients on chemotherapy. This becomes one of the main problems of nutrition in feeding cancer patients, because the moment we start giving any kind of immunoboosters, those immunoboosters starts or helps the proliferation of these Th1 helper cells, which in turn leads to phagocytosis or killing of their own cell. So this is basically the problem that we need to do without in critical care nutrition. But if there is enteral nutrition provided, then there is a separate pathway also which is stimulated. Now this separate pathway is done with the help of Th2 helper cells, which tends to curb the Th1 inflammatory, the unnecessary over response of the Th1 cells, and thus prevents the self-injury. As I've been talking about, this is just another, just once again reminding that gut disuse promotes SIRS, as I just said, through innate immunity as well as acquired immunity. Another thing, that it is established that antiviral mucosal defense is lost, and this is, as I have already mentioned, one of the reasons why early or overzealous use of parenteral nutrition leads to nosocomial infection in ICU patients or in critically ill patients. So let me now come to the quick immunological benefits of enteral feeding. As I already mentioned, this will provide the alternative pathway of the CD4 T cells, the T2 cells, which will help the T1 cells, which will suppress the overfunctioning of the T1 cells. Now, these special regulatory cells will actually counter not only the T1 cells but also the cytokines, which I mentioned earlier in the immunological model of what happens if there is continuous disuse of the gut mucosa due to the zealous use of parenteral nutrition. And finally, by starting our early enteral nutrition, we are able to achieve a balance between the inflammatory and the counter-inflammatory functions of our body, which helps in minimizing the criticalness of the illness and helps in reducing the length of stay of the patient in the ICU and also helps in reducing the entire course pattern of the illness. The second benefit that you can talk about is if there is a GI load, it will help in maintaining the normal mucosa, which I mentioned in my very first slide, have a good effect or good stimulatory effect on the beta cell system, that is the acquired immunity system. This will support the increase of the density of the IgA or the immunoglobulin.
আমি কিভাবে তোমাকে হেল্প করতে পারি? এটা তো কলেজে অ্যাডমিশন হেল্পলাইন বা ওই এক্সাম হেল্পলাইন দেওয়া আছে, সেখানে তুমি ফোন করো। সেটা আমি তাই তোমাদেরকে।
And as already mentioned in the first benefit, a balance between the Th2 and the Th1 cells, which helps in preventing exaggerated inflammatory response in the body. A few pointers once again, based on what I've been discussing so now. It has been seen that E. coli infection after 7 days of parenteral nutrition, patients with E. coli infection, there is an exaggerated response to pro-inflammatory stimulus. And in this case, it is the lipopolysaccharide, which is basically derived from the E. coli cells. And this has been manifested by higher load of tumor necrosis factor and cortisol. Cortisol can be measured in blood. It's normally done in ICU setups. It has been seen that if there is early enteral feeding, then the total hypermetabolic response, which is actually leading to the development of cachexia in the patient, blunts, reduces. So there is less hypermetabolic response. There is more retention of body protein mass, more retention of body nutrients. Another thing I want to point out about pancreatitis, since pancreatitis is one of the main patients that we encounter in this critical care setup in a normal hospital ICU, which poses a problem for feeding. Enterally fed, they will have low levels of CRP or the C-reactive protein, which is basically a marker of the inflammatory status of the body. They will have less oxidative stress, and SARS will be or can be prevented. There's a decrease in the Apache criteria and the Ranson criteria, which I explained in my very first slide, if we can maintain 7 days of enteral therapy. And this is something which I believe is the responsibility of us clinical nutritionists to convince the consultant physician or the surgeon that even for pancreatitis, we do not need to shift the patient to parenteral nutrition unless and until there are certain complete contraindication for enteral nutrition, which can be quickly summarized. If I talk about certain things which are contraindication for parenteral nutrition, can be a patient who is more than 60 years of age, has a very high level of unconsciousness. There is no possibility of drip feeding. There is only bolus feeding method available in the hospital. The patient has to be kept in a supine position. The gastric residual volume is very large. If such problems do not persist, then we should be insisting upon trying enteral nutrition, if not the standard therapy of oral nutrition, but at least enteral nutrition. Now, the problems that I mentioned about enteral nutrition can also be bypassed if certain techniques are used, though they are not always foolproof, but they do help in a lot of places. That is the trick of using percutaneous tube feeding. Enteral nutrition need not always be through Ryle's tube only. We can be using percutaneous tubes which ends in the small bowel area rather than in the gastric area. We skip the pylorus sphincter and then we insert the tube into the small bowels, and it has been seen that if nutrition or enteral nutrition, I would just like to clarify out here for the undergraduate students, any nutrition that is provided with the help of the GI system is termed as enteral nutrition. So please consider this to be as a part of enteral nutrition. This is commonly the jejunostomy feeding or the duodenal feeding that you are taught about. That is basically percutaneous tube feeding. Now, if percutaneous tube feeding, as I was saying, is done at the level of small bowels, then there will be less gastroesophageal regurgitation. One of the main problems of enteral nutrition through Ryle's tube is regurgitation and aspiration. Now, this aspiration, sometimes the fluid, as you can understand, in a busy hospital setup, not always is the patient being monitored. So this aspirated fluid might simply find its way into the lungs, causing aspirational pneumonia, which is life threatening. It has been noted that percutaneous tube feeding below the level of the pyloric sphincter does not increase or actually suppresses or minimizes pulmonary aspiration to a huge extent. Alongside, it minimizes the gastric colonization by unfavorable bacteria. Alongside, it has also been seen that to meet the target protein and the kilocalorie load that we want to give to the patient based on their Harris-Benedict equation, or the basal energy expenditure of the patient, can be easily done if I am using this percutaneous tube feeding or duodenal feeding or the jejunostomy tube feeding. Finally, it has also been seen, I was just talking about a huge gastric residue, which is contraindication to enteral feeding, or rather contraindication to tube feeding through the Ryle's tube or a nasogastric tube. Through this percutaneous duodenal feeding, we will often see that there is a reduction in the total gastric volume that is there when the patient is not being able to tolerate nasogastric feeding. But one thing is to be noted, once enteral feeding, especially percutaneous feeding, is started, there are certain parameters which has to be continuously monitored to establish that the nutrients that is being given to the patient are being assimilated. Clinically, the sign would be the absence of diarrhea. That will tell us that the nutrients are being assimilated, properly absorbed, and then assimilated and metabolized. And alongside blood glucose, blood triglyceride, blood urea nitrogen, and the creatinine ratio. Creatinine ratio being the albumin is to creatinine ratio, which is supposed to be less than 30 if it is normal, and if it is more than 300, then that is an indication of macroalbuminuria. Albuminuria meaning intact albumins in the urine. So these are some things that needs to be monitored if we are going in through percutaneous enteral nutrition. A quick recapitulation of everything I've been saying so far. It is always advised to start early enteral nutrition within 24 to 48 hours of admission. We can use, or we can think of using, small bowel feeding if nasogastric feeding is not is contraindicated rather. Elevation of the bed head. Use of motility agents. This can help in maintenance of the peristalsis and reducing those narcotics which induces unconsciousness. Sedatives, anxiolytics which induce unconsciousness to the patient. If possible, they are to be reduced. Even morphine derivatives, which sometimes cannot be avoided to control the pain, which is almost synergistic factor seen in critical care patient, but if possible to use less morphine derivatives, because all morphine derivatives and all opioids are known to induce antiperistalsis or vomiting. There will always be a chance of aspiration if there is a huge tendency of antiperistalsis. So we can always request the clinician to try and use less amount of opioid derivatives like tramadol and tapentadol, these kinds of common opioid derivatives that are used in the ICU protocol. And finally, what I was talking about, the continuous monitoring, there should be a protocol to evaluate the nutritional status, evaluate the amount of gastric residues, and to specify when enteral feeding is to be interrupted, and there has to be a paradigm shift to the parenteral nutrition. Quickly, if you look into the nutrient consideration for parenteral nutrition, one should not go more than 35 kilocalorie per kg of the actual body weight. This is bound to induce hyperglycemia in the patient. It has also been noted that patients who are receiving more than 77% of their kilocalories from carbohydrate sources, in both enteral and parenteral nutrition, there is a higher episodes of sepsis. Hypocalorie to isocalorie dose is best recommendation for both enteral and parenteral nutrition. One must also note loss of lean body mass or cachexia is a part of critical care, critical illnesses. So PEM and loss of body fat actually will increase the insulin sensitivity. And sometimes it is better to first address the oxidative state, the oxidative stress that the patient is undergoing, by not providing any proximate principles of nutrition, rather just giving certain immunonutrients like glutamine and antioxidants. And then the macronutrients and the proximate principles could be met. Proximate principles meaning the protein and fat should be met, and carbohydrate can be given by the third day. In case there has been use of parenteral nutrition, then immunonutrition can be continued through parenteral nutrition modes, while enterally we can start on with provision of the main proximate principles. One thing we must note, that is monitoring of the immunoresponse and cytokines may help to decide whether to stimulate or upgrade immune response through arginine and its nucleotides, or to downgrade through omega-3 fatty acids or other oils. And finally, this is just a graphical representation of how nutrients and nutritional therapy should be done in a critical care, which will help us to correct the nutritional deficiencies. And with this, I come to the end of my presentation. Thank you very much.